will be speaking today about some of her research and work. And so Dr. Ballard is the Director of Psychology and Behavior Research and the Director of Predoctoral Training at the Experimental Therapeutics and Pathophysiology branch in the National Institute of Mental Health. She trained as a clinical psychologist at the Catholic University of America and has extensive clinical experience working with suicidal patients. She completed her predoctoral internship at the Department of Veterans in Denver and a postdoctoral fellowship at Johns Hopkins School of Medicine. She has published over 100 articles, and her research interests include short-term risk factors for suicide and rapid-acting treatments for suicidal thoughts. So please join me in giving Dr. Ballard a gracious welcome and thanking her for sharing her time and energy with us to talk about this. Thank you.
Great, let me get this up. And okay, let me just duplicate. Is that the correct view?
Yes.
Yeah. Perfect. Okay, great. Well, thanks so much for inviting me here and joining me today, and for the nice introduction. Yes, I do have a suicide focus, and so I'm going to be talking about rapid acting therapeutics and potential targets for intervention. So I do have to say that I'm a federal employee and have no conflicts to disclose, but any opinions expressed are my very own and do not represent the United States government. I always like to end with take-home messages. And so overall, what I'm hoping to convince you all is that there's this intense need for treatment options for acute suicide risk. And I'm going to go through a little bit of what I mean by that. And then I don't think this is a sort of new, this isn't new information for this type of a group, but I do think our next generation treatments are going to look quite different than our sort of traditional therapies, you know, sort of just sort of psychotherapy in isolation or sort of a drug. And then my work really focuses on sort of biomarkers of response to suicide-focused interventions, and especially sort of moving beyond just self-report of suicidal thoughts. So this is the outline of my talk. I'm going to talk a bit about the barriers, the why we don't know more about how to treat suicide risk. Work does focus on ketamine, a glutamate modulator, as sort of this model, and then talk through a little bit of the biology and sort of what we've been working on in terms of suicide-focused interventions. So if people do not know, NIH gives out large gobs of money to research institutions, including Yale, but also has its own intramural program. And so I work at in Bethesda, Maryland, in this hospital, a research hospital, dedicated to research. There's no emergency room, there's no primary care. Anybody in the hospital has been recruited for a research protocol. We have our own inpatient unit where we can fly anybody in from around the country, potentially take them off their medications and do these really in-depth clinical trials, and can take advantage of the facilities that we have to really get at sort of neurobiological markers of treatment response. So I am going to give a broad summary of suicide rates because I think it's always important to return to this, that we know that this isn't just one unidimensional concept that occurs across all populations. In 2020, over 45,000 people died by suicide in the United States. And if you know what's happening with the most recent data, it's actually looking like the rate is crawling back up in 2021, at least. So what that means is 12.2 million adults seriously considered suicide, and 1.2 million adults tried to kill themselves. And so for every death by suicide, there's even more suicide-related outcomes in terms of hospitalizations for a suicide attempt, an emergency department visit related to suicide, self-reported suicide attempts, and then even suicidal thoughts. So there really is this sort of broad range and continuum, which also speaks to the difficulty in piecing apart sort of how do we think about treatment for these individuals, because there's sort of all of these different levels. A reminder that there is this important racial and ethnic component to suicide risk. The individuals at highest risk for suicide are American Indian, Alaska Natives. And in particular, they have a little bit of a different developmental trajectory that it's particularly sort of younger American Indian youth are the ones that are dying by suicide at higher rates. And then you have the non-Hispanic whites and then other racial groups. However, more recently, there's been sort of alarm that traditionally it's thought that sort of non-Hispanic Black Americans were at lower suicide risk, but that number, and with actually Asian Americans, it has been creeping up. And what's been particularly alarming is that there seems to be higher suicide rates in Black youth. And so NIH has a big focus on sort of trying to understand why that is, because this is going contrary to sort of decades of research about sort of suicide across ethnic groups. Important also to remember, if you've been a psych resident, I'm sure you know this, that women are more likely to attempt and consider suicide, but men are more likely to die by suicide. And so that influences any sort of research that you're thinking about, that oftentimes there's a preponderance of women in these samples because that's who's going to report the suicidal thoughts. But then when you're looking at markers of death, it's often men. It's complicated by the fact that many times men will use firearms, which are much more lethal, and you're much more likely to die on your first attempt rather than other methods that people use. And then there's the sort of differences by age group with, as is typical, sort of the oldest age group at the highest sort of overall, sort of more deaths by suicide in this group. I won't go through this too much, but it's just important to think about sort of rates versus overall numbers, that suicide is the leading cause, one of the leading causes of death, especially in younger folks, mostly because they don't die of things like heart disease and cancer at the same rates. So in overall sort of comparator, they're sort of second and third leading causes of death, but overall numbers, it's higher in the older age groups. And then that there's this important geographic component as well. So I am going to focus much on the biology, but like obviously as I'm bringing through, there's a really important demographic and then environmental considerations that we see much higher suicide rates out west. There's considerations of access to mental health care, access to firearms, sort of just social isolation in sort of these bigger, sort of more open states. But again, it's an open question. And so in this one, the darker blue represents higher suicide rates. So hopefully through that brief whirlwind, I've convinced you that suicidal thoughts and behaviors are a national crisis. I don't know if anybody has in their clinical work had somebody die by suicide, but it is very, very difficult when it happens. There was a suicide over a decade ago in the National Institutes of Health, and I can say that the repercussions with the folks that were here at the time sort of are still with people. And so the sort of saying is every 40 seconds, someone in the world dies by suicide, and then there's the people who are left to experience that grief. So this is a critical issue. Why don't we know more? Why don't we have sort of better and more clear treatments? First, there's the ethical concerns that suicidal individuals are very difficult to enroll into studies. And if anything, it appears that our clinical trials are getting more restrictive because there's the concerns about the adverse events and reporting requirements. It does appear that even over the last 10 to 20 years, suicidal individuals are more likely to be excluded from depression clinical trials, which means you're having this research base for individuals with depression, and they are excluding this key patient population. And so we don't actually know for a lot of our treatments how well they work with suicidal individuals because they're not in the clinical trials. Then there's the conflation of long and acute suicide risk factors. And so this is a key point that I'll go through a number of ways. But basically, when you do these huge meta-analyses and look at sort of suicide research over the last 50 years, we're basically looking at the same factors over and over again, and our sort of ability to predict hasn't seemed to improve. There's no potential objective markers for suicide risk. There's a lot of reasons why somebody might minimize suicidal thoughts. They might not want to be hospitalized. They might worry about, they want to be discharged. They might just want to get out of your office. And so a lot of the work very much relies on self-report of symptoms. And then lastly, for the treatments that we have, we don't really understand why they work. And we have very few biomarkers of suicide ideation response. So I bring this up about acute versus long-term is that there's this fundamental tension in terms of clinical decision-making versus research evidence. When you are in an emergency department situation or sort of a crisis, oftentimes what you are being asked to do as the clinician is, what is this person going to do in the next sort of 24, 48 hours? Does this person need to be hospitalized right now? What is going to happen to them in the short term? That's most likely the clinical question that you are being asked to address. The research is much more focused on the long term about, will this person kill themselves someday? And it really gets to the acute risk versus chronic risk. So it's important to know that, okay, a family history of suicide, okay, history of trauma exposure, that's going to put somebody at suicide risk over the long term. But what does this person need right now? You need to know sort of what are the key factors that's going to tell you about their behavior in the short term. And so again, thinking about acute risk versus long risk. And so this is another way to think about this. This is fluid vulnerability theory, is that suicide is not a diagnosis, at least according to the DSM. It's not sort of a clean major depressive episode. It's usually a very short-term crisis state around the time of the decision to act on the suicidal behavior. And so this sort of model is looking at, okay, you have sort of suicide risk that sort of fluctuates around a set point, and then usually there's some sort of event. There's some, it's a breakup, it's sort of a fight with somebody, it's your depression getting worse, it's your psychosis getting worse. And then you have sort of this acute suicide crisis in which you're much more likely to potentially sort of take steps to end your life. And so a lot of the work that we're interested in is what was different at that state as compared to here. And so this is looking at this another way. If you think about the continuum of suicide risk, that most people, are at low suicide risk. They've never seriously considered it. They don't have sort of serious psychiatric diagnoses. There's individuals that have psychiatric diagnoses. Plenty of these individuals do not seriously consider suicide, do not make these attempts. There's people who have attempted at some point in their life, but have received treatment or sort of moved on from that. So they're at higher risk over the long term, but they're not in a crisis state right now. And then sort of the crisis itself. And so I bring this up to you to sort of think about, when we think about interventions, including things like psychedelics, when are we talking about across this continuum that we're intervening? Are you thinking of something that's going to intervene at the time of the suicide crisis? Are you thinking about sort of earlier in development before somebody even develops the psychiatric diagnosis? Are you doing this after a suicide crisis has resolved in order to think about, okay, how am I going to give people sort of the coping strategies, the coping skills to prevent another suicide crisis from occurring? So again, I think that sort of this element of time and where people are across this continuum is often lost sort of when we're thinking about sort of what would treating suicide mean. And then also like maybe you do the treatment right before somebody goes into the acute crisis state. So what do we have in terms of treatment? We have the pharmacotherapies. There's only one at this point sort of pill form of medication, FDA approved for suicide risk is clozapine. And there's longstanding use of lithium. There's psychotherapies, including cognitive behavioral therapy and dialectical behavioral therapy. And then, of course, there's the longstanding use of electroconvulsive therapy. The work that we do at NIH is really focused on next generation treatments. I work under Dr. Carlos Cerati, who's been at the forefront of ketamine research. And then there's sort of new work related to TMS. And we have another PI in our group, Dr. Holly Lisenby, who's really focused on sort of new forms of ECT and TMS. Again, getting into this element of time, there are these sort of critical windows when you are most worried about sort of suicide risk, especially when you're thinking about our more traditional medications. So what we know is that the highest time for suicide risk when you're taking sort of a more traditional SSRI or other antidepressant is the first 9 days. We also know that those sort of transitions in care from psychiatric admission to sort of your follow-up appointment with a psychiatrist, psychologist, nurse practitioner are also sort of high risk times because you sort of don't know the clinician very well, you're sort of getting stabilized. So my point is that we have these underlying gaps in care. At the same time, our medications don't work as well. And so that really is a gap in terms of when we're thinking about treatment. And so what I am very much focused on is how do we initiate treatment at the point where somebody is sort of in a suicide crisis or maybe coming down a little bit so that we can resolve this crisis. And then we can connect individuals to longer term treatments, which we know that they work. So how do we bring down suicide risk in the short term, then connect people with the lithium, the dialectical behavioral therapy, the like, that's going to sort of prevent even other suicide crises or attempts from emerging. So that was the overall sort of perspective of sort of the viewpoint that I bring to my research. I guess I'll just take a second to see if anybody has any questions on that. Nope. Okay. Great.
Sorry, I hate to. I just curious, and this is a very granular, detailed question, but I'm curious the elevation in risk in those like that 9-day window or whatever it was. Mm-hmm. Do you have a sense of like what is the magnitude of that elevation in risk? Because I've heard that, right? I'm always wondering, well, what is like the risk ratio, if you will? You know, what's the effect size, so to speak?
So a lot of this comes out with the black box warning with sort of SSRIs with adolescents and sort of seeing sort of this high risk period. The overall problem is suicide is such a low base rate phenomenon anyway. And so, okay, well, it's 100% more risk because there was 1 as compared to 2 or something like that. So I can't speak to that. I know that comes from sort of these huge data sets. And there's the question of, do our medications, you know, agitating people, or it's treating the depression, but not the anxiety? I've heard all sorts of things about sort of, or it just could be, it's just taking a while to get full effects and people are frustrated that they don't feel better right away. You know, there could be lots of different hypotheses.
Yeah, and just for context, I ask in part because I've heard that, and then I always kind of wonder, like, and I gotta have to look at the data myself, but I'm always like, are we getting really worked up about this thing that is like maybe the effect size is actually minuscule and they just data mined this massive data set and they came up with a p-value? Sorry, I don't know. I was just curious, but we can move on and I'll do a little homework myself.
I mean, again, I'm not a psychiatrist, but like I think there was a concern that a lot of these warnings would prevent people from prescribing these medications, because overall there does seem to be treating depression is a good thing to do with a suicidal individual, regardless. But yes, I can't say, oh, it's, you know, it's so clinically significant, but the end result, what you should be doing is monitoring. And I don't think there's any harm in sort of making sure you start somebody at risk on a medication that you sort of check in with them. Anything else?
I have a question. I wondered about, you mentioned lithium and antidepressants, getting them on a long-term care. What about, and perhaps you would address this later on the talk, but what about ketamine as a long-term intervention for not just suicidality, but depression as well?
Yeah, so that's the focus of sort of my next section is around ketamine. We have really focused on sort of the brief sort of 1 infusion. We have studies looking at repeated doses. I'm really interested in thinking about, is ketamine sort of a long-term solution? It doesn't quite, I don't know. I feel a little bit mixed on that. As compared to synergizing with other interventions or sort of harnessing what we know about ketamine for more long-term treatment. But I think it's, I'll get into this later. I think it's I think with ketamine, and then you all know more with the psychedelics, it's a really interesting place to be, because usually what we're taught is you do an intervention and, you know, it takes 15 years for the intervention to reach the community. And as of now, there's just so many more community practitioners giving long-term ketamine than has been done in research. It's just really much faster. The pickup has been much faster. And so I think a lot of these questions are really going to be answered by patient registries and sort of understanding sort of what are these long-term effects, because my understanding is there's people getting ketamine for weeks and weeks, months and months out there. Okay, so I'll go through this a little bit. Time. Oh, we're good. So overall, sort of the fundamental challenge in neuroscience is modeling the brain. That it is very difficult to sort of find a drug and take it to market. It's estimated, as I said, like a drug will take 15 years and $4 billion. So many drugs are evaluated and so few are coming out. And in terms of clinical approvals, just across the board, I'm not talking about suicide, just, you know, sort of psychiatric, CNS more broadly, it's just really hard to get a drug approved. And so leading up, especially to the ketamine story, many of our pharmaceutical companies sort of went out of the psychiatric treatment business. So they sort of dropped their R&D related to brain disorders, to psychiatry, just because it was so hard to develop these drugs. What I'm not going to go through is the biology of ketamine. I have great associates. There's great literature on this. But it's obviously a widely used dissociative anesthetic, very familiar to anesthesiologists. It does have the psychomimetic property. It is abused as a club drug. It was used as a model of schizophrenia in a lot of interesting healthy volunteer work in the 90s. And then obviously Berman et al. Described this potential antidepressant effect. So again, not going to go through the neurobiology. This is very much the work of my lab and Dr. Zarate, but we know that ketamine has influences at many parts of neurobiological systems and even just many factors of the synapse. And so it really represents a distinct mechanism, a distinct sort of way of getting treatment into individuals, a distinct response to intervention that I think has really excited the field and sort of opened people's minds to think about sort of other forms of treatment. I'm not gonna, again, considering the audience, I sort of give this picture just to show how sort of medical of an environment that we do ketamine research in our clinical trials, but this is very much done on a research unit. My understanding is a lot of sort of more community practices. It's a little bit more like a yoga studio. There's a little bit more of a calm, relaxed environment, but we really do, even with sort of the 2 nurses and 1 doc and the beeping and the, you know, huge binder of rating scales that we're using, we still are able to see these really important antidepressant and anti-suicidal effects. So these are Dr. Zarate's initial studies related to depression. This is there to sort of highlight sort of the rapid effects that we do see, these rapid effects in depression within minutes to hours, with the sort of largest effect at day 1 that seems to start sort of tapering off to get it to the point that was asked before at day 7, and really rarely find sort of statistically significant effects by day 14. And we use a saline placebo in our research due to the focus on biomarkers, but you still see effects a little bit attenuated, but when you use the midazolam placebo. And so then this is also with bipolar depression, which is always a concern because of the concern of putting somebody into a manic state, but we have shown good effects with bipolar disorder. So where I came into this was thinking about suicidal thoughts. And so a lot of this initial work came in as sort of just a secondary outcome of our depression clinical trials, then also seeing these effects on suicidal thoughts because there's so little out there, especially on that sort of acute suicide state. Really interested in this work. And so what we see overall is that you see this reduction in suicidal thoughts Again, the largest effect size at day 1, and it does appear to be independent of antidepressant effects. Obviously, it's somewhat related, but you do see sometimes people will have a depressive effect, but not a suicide effect. Sometimes you will see a suicide effect and not a depressive effect. And there's been a number of other studies, especially studies that are a little bit more focused on suicide. Some mixed findings, but overall, you do generally see this effect on suicidal thoughts. This is just another recent study. I liked this because it had this visual abstract, but this was saline placebo as compared to ketamine in sort of a much larger study of individuals selected for suicide risk. So overall, you see sort of these reductions. Now I'm going to get into sort of how we think about sort of who could best respond to this, and it's tricky. So this is sort of trajectories of suicidal thoughts in our data from baseline to day 1 to day 2, day 3. As you can see, that's very messy. Then we've been able to isolate a little bit of, there's folks that seem to not respond at all. There's sort of responders that people have a little bit of a reduction in suicidal thoughts. And then there's what we call remitters. So individuals whose sort of suicidal thoughts seem to sort of completely go away. When you get these sorts of results, the question is always, oh, can we predict this from the beginning through a bunch of potential markers at there? Some things came out like related to age, history of self-injury, history of sexual abuse. One sort of IL-5 blood biomarker. But I give this as an example to just say when you're sort of throwing the kitchen sink at these sorts of analyses, it's really hard to know, sort of why are we finding the effects that we are. And so I think that's been a struggle to find, at least in the ketamine literature, what are these predictors? I was just involved with the huge meta-analysis, and they ran all the fancy statistics and really struggled to find moderators. There's been a lot of interesting work on sort of family history of alcohol dependence, BMI. There's a lot of factors that people are looking into, but it's really A, difficult to find, and B, difficult to have the sample size to really look at these biomarkers sort of quite clearly. And so bringing it back to sort of my earlier points about the implications for emergency treatment, a rapid acting treatment could be initiated with somebody who's in crisis. We can decrease the symptoms in the short term. But getting back to the question that was asked, what happens after these effects wear off? Do we do repeat doses? Do we do sort of repeated doses for a while, weekly or a couple times a week, and then move to once a week and then once a month? I'm sure people are working out this in the community. Linkage to other pharmacological treatment, and then linkage to psychosocial treatment. There's a lot of interesting work coming out in terms of like maybe sort of brief sort of neurocognitive interventions and sort of the linkage between ketamine and that. There isn't as much sort of ketamine and psychotherapy that I think there is in the psychedelic literature, but it's certainly an area of interest. And then as I alluded to, it's remarkable sort of the relationship of the research to clinical care, that we just see this huge explosion in providers in the community sort of working with this, mostly because ketamine is a known drug, sort of there's been decades of research with it sort of in the anesthesia realm. And sort of, it's just launched in terms of a lot of people getting it in the community. So what I do not study specifically is S-ketamine or Spravato, which is an intranasal version of S-ketamine sponsored by Janssen. What's been interesting to watch is the research on suicide ideation in these randomized trials. A lot of the Janssen studies did not show an effect on suicidal thoughts. There can be so many different reasons, especially because we don't do as many clinical trials on suicidal thoughts. So there's a lot of factors of patient selection and placebo effect and your outcome. But it has been sort of remarkable to sort of think about, okay, why would we see potential effects in ketamine and not in these industry-sponsored S-ketamine research? And then obviously you all know about this. There's, this interest in other psychedelics. When I'm sort of explaining this to sort of an audience that is not as focused on psychedelics, I do sort of highlight that this is this burgeoning area with rapid acting effects. And I feel like, as not an expert, there is sort of a much more willingness to consider the sort of treatment experience integrated with sort of a therapeutic experience as well. I feel like in our work, there's a lot of work on, okay, what's the next drug that would have the antidepressant effects of ketamine, but is not going to have the dissociative side effects. That's sort of the focus. And it seems to sort of be the other way around in a lot of the psychedelic literature, but I would be happy to discuss that more at the end of this. Janssen did get the indication for S-ketamine, but I'm sort of showing you sort of the MADRS scores, and then, oh, I thought I had the suicide scores. So overall, sort of the potential effects, and then I usually have a graphic that shows sort of the suicide effects that don't necessarily seem to see a separation. Then with my last little bit, I'm going to touch on potential biomarkers of response to suicide-focused intervention. So all of this is still ketamine. So one analysis has been, we were able to do PET imaging before and after, and looking at glucose metabolism in the infralimbic cortex was sort of associated with suicidal thoughts, and sort of changes in this area was associated with changes in suicidal thoughts, but we're not necessarily seeing this relationship with depression. I'm particularly interested in sleep. I think that we know that sleep-reported difficulties are associated with sort of long-term risk for suicide risk, but I also wonder if it's a short-term acute risk factor. When I've worked with suicidal individuals, when they're describing the day that they attempted suicide, oftentimes they did not sleep well the night before. We know that the time period from midnight to 5 a.m. is a particularly high-risk time for suicide death. When you adjust for a sort of number of people awake, there's a number of factors related to this. You have much, sort of reduced access to your clinical supports or sort of emotional supports during that time. It's often a time where people are coming off of medication use or alcohol use. Our brains are supposed to be asleep during these times. Often you don't make your best decisions at sort of 3 o'clock in the morning. So sort of thinking through a lot of these rapid acting treatments and their influence on sleep, I think, is an exciting area of research. And so our initial studies, we are able to do sleep studies with our patients and healthy controls. You can see sort of midnight to 5 a.m. in these graphics. Each line represents the sleep of one individual. So you can see there's much more wakefulness over the course of the night in the depressed patients as compared to a sample of healthy volunteers. And so what we did was look at individuals with suicidal thoughts as compared to depressed individuals without suicidal thoughts. And basically, if you put this all in the model, time awake spent at 4 a.m. predicted suicidal thoughts the next day when adjusting for depression, adjusting for age, diagnosis, and the like. And what's particularly relevant to this group is then looking at what happens after ketamine. And so we have patients with continued suicidal thoughts after ketamine. So those are individuals who had suicidal thoughts, received ketamine, went to sleep that night, woke up the next morning, and still had suicidal thoughts. You can see sort of the level of wakefulness with those individuals. And then on the right, you have individuals without suicidal thoughts after ketamine. So those are the individuals who had suicidal thoughts, received ketamine, went to sleep that night, and woke up and said, no, there's no more suicidal thoughts. And so you can really see this potential normalization of the sleep associated with a suicide ideation response to ketamine. So sort of looking at sort of wakefulness as a sort of a dichotomous variable is one way to look at it. More recently, we have an updated approach to look at this link. And this is a lot of work focused with Dr. Didi Greenstein, a statistician in our group, but really looking at sort of the alpha frequencies. And she has these methods, a multi-level functional principal components analysis, to sort of really break down these frequencies and understand what's going on in the brain over the course of the night. So how I usually think about this, if you've ever done a principal components analysis for an assessment, this is very similar, but it's looking at sort of functions in brainwaves over time. And so we looked at alpha and beta due to their relationship with overall wakefulness. and disrupted sleep, you get these potential components. So for alpha on top and beta on bottom, we have the first component, sort of PC1, accounting for overall shift in power over time. But then you get these potential representations of oscillatory patterns or fluctuations. So you see this similarly in alpha and beta. So like one component is adjusting for sort of overall sort of up and down shift, and then one adjusting for sort of oscillations. And so where this comes in is we correlated each of these scores with suicidal thoughts. And what we found is this PC2, this particular sort of beta wave fluctuation, was associated with suicidal thoughts. Again, sort of taking it one step deeper into the brain about sort of potential hyperarousal processes over the night, maybe sort of leading to these patterns of wakefulness as associated with next day suicidal thoughts. And so we're still working on understanding this in the context of ketamine. I'm hopeful in the next year we'll have sort of results of that, but that would be the next step, is sort of, okay, looking at these brain waves over the course of the night, what happens after somebody receives ketamine, and is this potentially an explanatory model for the rapid effects? Then I have a lot of wonderful MEG researchers. We know that gamma power is one of our more reliable biomarkers of ketamine response. And so she was able to look at gamma power in different regions of the brain. I sort of give this graphic more to show you this differential pattern of activation. You have suicidal ideation on the top and depression on the bottom. So we're seeing, again, these potential different areas of the brain associated with suicide as compared to depression. And then she's able to do these very complex models of AMPA and NMDA receptor glutamatergic signaling in different regions of the brain. And again, showing potential differences in what we found with depression as compared to suicidal thoughts. Then another MEG expert, Dr. Allison Nugent, wanted to look at overall connectivity. And so we worked to identify a number of sort of depression constructs like depressed mood, tension, negative thoughts, amotivation, and then suicidal thoughts. And basically she put everything into her complex model and found she was really only able to predict suicidal thoughts through these sort of connectivity couplings, specifically these low frequency power fluctuations in delta and theta with alpha and beta power. So it's just interesting. Then you're trying to sort of predict anything related to depression, but there was this particular relationship with suicidal thoughts. So as of now, what we're doing a lot of is linking sort of self-reported suicidal thoughts to sort of underlying biological mechanisms. And so what I've been really interested in is how do we have tasks? How do we have sort of probes for the suicidal process? And so if you have taken, I don't know about you all, but we have to take a lot of implicit bias trainings at our work. So they've probably talked about the implicit association task, which I know is a little bit controversial within social psychology, but if you want to learn more about its sort of social psychology influence, I encourage you to go to implicit.harvard.edu and find out more. But basically, it's a task that looks at response times to certain stimuli, which is meant to sort of uncover an implicit bias that some individual might not say explicitly, but sort of has in terms of how they make connections between concepts in the brain. So in 2007, Matt Knock up at Harvard developed a self-harm version of the IAT. So it's a 5-minute sort of behavioral task, and has been shown to predict sort of long-term risk for suicide attempts, and has been replicated a number of times. There does not seem to be any harm. And so I'll walk you through what that looks like. So you have categories sort of at the top of the screen right now. You have death or me, and then on the right, you have life or not me. So you get a target word, and then you're just asked to categorize the word into the left or the right group. So suicide is on the death or me side. So you would just say left. Alive would be on the life side. Myself would be on the death or me. Them would be on the life or not me. So then the categories change. And so now you see the life or me, and then death or not me. So again, you see the same words in different order, but the same words. So suicide is now and the death are not me. Alive is now in life. Suicide again and alive. Myself and them. So what's important on this is, again, it's basically the same words and it's the same general categories. It's just the categories have slightly shifted. So individuals at the highest risk for suicide are faster at responding correctly in this condition, the death or me condition, as compared to the life or me condition. And so that is thought to represent this type of implicit bias between the self and death-related processes. And so this, again, is a behavioral task that we have brought into the scanner. And so we're able to do a pilot at 3T fMRI and MEG, and overall see, again, same words, but slightly different structure, sort of contrasts in sort of brain regions. And so can go through this, but what we did see similarities across these two modalities is in the anterior insula, which is associated with the salience network. And then I am working with a postdoc, Steve LaMontagne, that is looking at this across a suicidal sample. And so what he's finding is the potential behavioral effects that overall individuals at the highest suicide risk seem to have slightly different scores on this sort of metric, which we would be expected. So that's what you see on the left, but then also sort of differential patterns of activation on MEG in response to this task. So group by condition effects in the posterior cingulate, right insula, and orbital frontal cortex. And in particular, in the high risk group, you see differences in the orbital frontal cortex in the sort of self-left death versus life condition. And then in a very, very small pilot trial, we do have people who have recently had a suicide crisis and then received ketamine, and you see this sort of reduction in gamma power, but specifically in the self-death condition, sort of making them look a bit more like our healthy volunteers. So again, very, very preliminary. You don't sort of put too much stock in 5 participants, but really serves as a proof of concept that this could potentially be some sort of task that we could use that doesn't necessarily just rely on somebody talking about their suicidal thoughts. So summary and take-home messages. Again, I hope I've convinced you about the sparse pharmacological treatments that we have, and that we really need to think through what our next treatments are going to be. I think it's very clear that they're going to be delivered in different ways, but I think they're also going to have a different sort of speed of onset. We do have these potential biomarkers to think through sort of why these treatments might work, what are the sort of suicide-related indications. And I hope, you know, when Max asked me to be part of this, sort of hoping I've sort of framed this in a way, sort of thinking about suicide risk isn't just sort of a diagnosis, but it really is sort of this matter of time. And so if we're thinking about using sort of these new medications to treat suicide risk, it's really going to matter. Are you thinking about the acute crisis? Are you thinking about preventing future episodes? That I think is just particularly critical to think about in the context of suicide risk. I like to provide this info just so you know and can pass along to any patients. There's 988, the suicide crisis line and crisis text line. And then I work with an enormous, wonderful group of multidisciplinary individuals, including my PI, Carlos Serrati. So that was it, and I can stop sharing. And I think we're right at 50, so that's good.
Well, Dr. Ballard, thank you so much for that presentation. Yeah, quite a range of research and information you just presented there, so thank you. And yeah, folks, for anyone who has questions, what I'd ask is, you know, use the raise hand function. It just prevents the whole like swarm of people speaking over each other inadvertently. So if you have questions, use the raise hand function and we'll call on you, and then we can just kind of have a hopefully fairly orderly and interesting discussion here. I can start us off with a question and just to get the ball rolling here. And I guess I wonder, one of my questions with ketamine is, because we can use it intravenously, you know, this question of both the concentration and the duration. of the dose. And I'm curious, because I know there's some thinking out there that the duration, at least with psychedelics, is that the duration of the experience, the subjective effects, if you will, can be correlated with or predictive of the duration of the benefits, so to speak. And, conventionally, ketamine infusions are, 40 or 50 minutes. But I have seen research, often in a chronic pain population, they'll do like much longer infusions, and that there's a huge amount of data on that. But I'm just curious from your perspective, if you think that there could be some benefit to either higher doses or longer duration, because right now we're like it's like a pretty standard approach, and it doesn't seem like there's a whole lot of exploration or research and other variables there.
Yeah, so it's very true that sort of Berman, they picked this dose, and people sort of went through it with it this whole time. And I know the dose finding study that I think was coordinated up at Harvard overall did sort of select 0.5 milligrams per kilogram as sort of the most optimal dose. But in the research environment, I don't know if there's been sort of a lot of looking into sort of different formats. But again, it's sort of the clinical versus research is that I'm near certain that people are exploring this elsewhere. I think to get at your point about the dissociative effects, I don't know if that was quite your question, but I think it's an interesting one because we've really seen mixed results. The one paper out of our group was able to show that the dissociative effects of ketamine was associated with the antidepressant response, but we've not been able to replicate that in future samples. And my understanding from meta-analyses, it's not been replicated. But at the same time, we haven't found a drug that has ketamine's effects without the dissociative effects. So there's sort of a lot of different ways to think about it. Like, do you just look at the symptoms, or do you say, well, how are we going to find another drug with these, very important antidepressant effects that doesn't have it? And so far, we haven't found that. Does that make sense? So there's like lots of different ways to get at what is necessary for the antidepressant response. I think for higher doses, you just worry about sort of increased side effects and, K-holes, there's a name for that for a reason, and sort of being very careful about sort of what you're doing with these vulnerable individuals.
Yeah. Thank you for that. And definitely a frontier that I think there's far more questions than answers at this point. So if anybody else,
a hand.
Yeah, I know, Sean, it looked like you had raised your hand, but maybe you took it down. But you can still ask your question if you got one.
On the question of long-term ketamine, I know you made some comments in response to my first question. And the other more general question, which you might or might not want to get into, but it's sort of follow-up in way of what Bob asked. We know that for psychedelic compounds, the set and setting are very important, and you give a slide showing your setting, which is quite clinical. Have you given any thoughts to trying to get a more comfortable setting that still conduct your research? Thank you.
So I think I got the last part, but I'm not sure about the first part. So about the setting, it's interesting, we try to make it a little nicer. Like we try to turn down the lights and tell people to be quiet, but it's on an inpatient unit, and there's still sort of a medicalized setting. Actually, we're going the other direction is that we have trials where people are in a scanner. So they're in a narrow tube in the dark, hearing a lot of loud noises at them. So we do it during MEG and then 3T MRI plus EEG. So they have, electrodes sort of stuck to them. So I would say, I think we are helping the field by going the other direction in terms of, frankly, a little bit more unpleasant settings to have this. But I am curious. I'd love at some point to tour some of these settings and understand it a bit more. But I do, wonder about sort of the environmental effects, because of course there would be an influence. We know there's environmental influences on everything. Otherwise, advertising wouldn't work. It is interesting to think about. And so I apologize, I didn't catch your first part of your question. I don't know, Rob, if you did.
Yeah, I was having a hard time. I don't know, Sean, if there's a microphone issue there, but if you speak up or maybe come a little bit closer, that might help.
Okay, sorry about that. Is that better?
A little bit better.
So I just wanted to ask about if you wanted to or could expand a little further on your preliminary comments on long-term ketamine use. Thank you.
So, like I said, we don't do that. Like, we're in the midst of our studies right now. Anecdotally, for the suicidal patients that I have, I've really seen a range of, so we do up to 5 infusions. That we'll have people who have a great response to the first one and then don't have a great response to the second one. And they are quite sad and devastated to sort of have that, like to have a taste of what it felt like to be sort of non-depressed or suicidal. And then sort of have that come back. And then I've had people who've like loved it and were feeling great at the end of the 5 infusions. And so again, very small sample size, very anecdotal, but I would be curious. I would assume it's just going to be like any other treatment, that there's going to be the people that it's great for, and then there's the people that it's not going to work potentially biologically, but as a psychologist, then I'm thinking about what's that going to mean psychologically when something like that stops working. Because I think that's an interesting question, especially if somebody initially had a response and, like I said, initially sort of felt like that fog had lifted, and then sort of it comes back and it doesn't seem to budge.
Scott, I see you've got your hand raised, so feel free to.
Yeah, I was just going to comment on that because I'm a primary care physician that treats people with sublingual ketamine for treatment-resistant depression, and I do treat them on an ongoing basis. And what I would tell you anecdotally is, in my patient population that has treatment-resistant depression with suicidality, if a person has a positive response to ketamine, and we continue their treatment, they continue to stay at a baseline of mood, and anecdotally, suicidality stays at a baseline as well. And some of my patients I've been treating with ketamine for 2 years. And they're people that say, depression runs in my family. I remember being depressed when I was 5 years old. I've been treated with other medicines for 10 or 20 years and failed everything. And then they have a positive response to ketamine.
That's great. That's great to know. And like I said, I think there's this difference between the clinical knowledge in the community and sort of what we're able to replicate in sort of these research environments. So that's really interesting to hear.
Just to tie a few questions together, because I'm also starting to do some ketamine in the community, is how to know when we're using different routes of administration and doses. It's just, that's the thing that's I find challenging entering this area of ketamine practice, is with the research all being done with IV and 0.5 mg per kg mostly. Some of the guesswork that's involved when using oral lozenges or intramuscular, and sort of titrating the dose to effect versus experience, and especially with suicidality, whether to think that the higher doses are more effective, or, really just feeling like there's still a lot of gaps in the actual application of this. And I wonder, Dr. Ballard, if you just have any thoughts about, as you showed that spike of use in the community, sort of what the best practices are when treating patients with suicidality out in the community.
Yeah, I mean, and I know that there was sort of a task force that had sort of a statement on what sort of best practices would be, but that seems like that actually needs to be updated already, sort of with these different questions. It's been interesting. We have research where we're following up with our patients, and a lot of our, not a lot, but a fair amount of our patients, do the clinical trial and then seek it out in the community. And so that's interesting work to sort of look at, and we want to look at predictors. But then the other way is, it used to be when we started that ketamine, that you could only really get ketamine in these clinical trials. And now we have people who are like, well, I was on the lozengers and then they stopped working, you know, like that already are sort of mini experts sort of in these administrations and are teaching our clinicians and screeners about sort of their experiences. And sort of, it's sort of now working the other way, that there are the people with these experiences and maybe this one route didn't work. And so now they want to sort of come here and sort of do it in a more medical environment. So I would never presume to say like, I know best about sort of all of this, but again, it's just so striking that usually you're dragging people to do evidence-based treatment and then to sort of do the uptake from the research, but it's really sort of been the opposite with the ketamine story.
Yeah, and my only other somewhat related question is just what you make out of that data you shared that with S-ketamine, that it didn't show that effect, and the research with generic ketamine has shown it. Is it just kind of a sample size issue, or do you think there's actually a difference between the medications for this for suicidality?
So I guess there's a couple of factors. You know, there could, you know, S-ketamine is a slightly different formulation. So my boss is very interested in sort of the R-ketamine route, sort of the enantiomer, and sort of going after a different sort of ketamine metabolite, sort of as the mechanism. And so he might say it's a different enough drug. And so we really need to see whether this H&K drug sort of does have the suicidal effects, but like the clinical trials haven't been done. So there's the potential of just sort of, it's just a different enough biology. What my worry is like, there's just so much we don't know about the placebo effect. Like I have initial data showing that the suicide is particularly reactive to the placebo effect. There's also, like I'm saying, these fluctuations in suicidal thoughts over time. So I don't know, you know, like these are great studies and they're very, very competent people, but there's just not the long-standing history of understanding how to do a suicide trial like we do for a depression trial. And so I worry that, you know, there was this burst of interest in suicide trials, and then we're going to get a few failures, and then people will say, oh, we can't treat suicide, and then sort of move on. So I'm particularly interested in sort of understanding sort of these design elements and what are the appropriate outcomes, because I would hope that S-ketamine has a suicidal effect. And I just wonder if we're just not using the correct tools. I have no basis of saying that, but again, I think this is too important not to take sort of these sort of clinical trial design questions seriously.
Thank you. I will pass it over to Rachel.
Hi, yes, thank you. I was curious, have you or has anyone, you know, looked at effects of ketamine treatments in addition to kind of post-session discussions of patient experiences with the ketamine treatments? I just know I have a few loved ones who have had the experience of ketamine, who have been suicidal, who have both been in clinical trials using ketamine and also just kind of informally getting it from like the street, and typically just their experiences, both in the trials and just using it casually, have been very different when they've been able to discuss the experiences afterwards, whether it's with a therapist or just kind of like informally with either a friend or a nurse, just because these experiences are so intense. And some of my friends have actually described their experience on ketamine as traumatic in and of itself, even though they have come to like really kind of life-changing realizations while on ketamine. So I'm just curious, like, has that been analyzed? Like, you know, the effect of ketamine versus ketamine plus this unpacking, I guess.
So I know there's work going on that does this, and I would assume that that's going to be a little bit more matter of course of people from the community that sort of run these clinics can speak to that. I'd be curious to know more. I think you make a huge point that it's not a positive experience for everybody, and can be sort of daunting in and of itself. A lot of the sort of randomized trial work I know of usually focuses on something, it's usually something very specific. It's like, there's the interesting work on ketamine and motivational enhancement therapy for sort of alcohol use disorder, or ketamine plus this specific implicit association sort of training neurocognitive task. So I'm not as I know that there's, sort of a lot of descriptive and really interesting work on sort of a little bit more of a, not quite guided is what you're talking about, but more just sort of open-ended discussion. But I don't know offhand of trials. What we are starting to do is sort of build that into the trials that I do related to suicide, as sort of, it's not quite therapy, but just have them describe it. And then we're videotaping it so that we can sort of analyze sort of how people talk about their experience, and then even how sort of their facial expressions change. Because I'm really interested in that. But like I said, with sort of the environmental question, like also with the understanding that I think inherently it's very different to get it in a trial that's on a research unit as compared to sort of a more comfortable setting.
Definitely. Okay, thank you.
All right, well, we can go back to Sean here. If you have a question, just encourage you, Sean. Coming closer to your computer and maybe speak a little bit more loudly, so hopefully we can hear you a little bit better.
Okay, first I'll unmute. How about that? So Dr. Ballard, and again, you may not want to answer this question because it's a little bit sideways, but I just wonder, and I'm sure a lot of people here have the same question from time to time, is you've mentioned psychedelics, and ketamine obviously is a psychedelic as well, or has psychedelic effects. But I wonder, what is your opinion as a researcher about the setup for standard clinical trials, the things that we demand of standard clinical trials when you're trying to investigate psychedelics? I mean, the big criticism of the studies that were done in the 60s was they weren't blinded. And so there is an attempt to blind studies here. But if you're doing a study on LSD and you're giving someone niacin or something like that, and they, in a half an hour, people know they've got the LSD. So I'm wondering if you have any thoughts, or if the research world is having any thoughts about the whole way of approaching research on psychedelics. And I understand it's not exactly pertaining to your talk, but I'd be interested in your opinion.
Yeah. So the blinding is always, it's always an issue with ketamine or not. We do saline, so people, when somebody is on something as compared to salt water. And so there's always sort of that question. And I would assume there would be sort of the struggle with sort of, I guess, more traditional psychedelics or the like. I think as a psychologist, where I'm curious and concerned is sort of thinking about sort of this sort of the assistance and sort of, is that therapy? How do we standardize? How do we study it? Is it the combination of both? But how do you, in good conscience, have somebody then do the psychedelics without the help if you're worried, especially with a very long experience, that sort of somebody might have difficulty? So, and it's hard to define what therapy is even outside of a psychedelic session, especially from my understanding, can be quite long. And that's not sort of what traditional sort of psychotherapy usually looks like. So anyway, yes, I feel, like it's always the hot topic at the conferences. Everybody wants to know about psychedelics. So I'm always excited as the next person to learn about it. But I sort of wrestle with an understanding of the study design, especially from sort of the assistance side, and sort of, is it therapy? Is it not? Is it essential? Is it not? What does that even mean in terms of mechanism, if it's required? And then how do you study that? Because I think sort of the folks that I work with, more traditional model is, okay, and then you study it in the mouse, and then you get the mouse less depressed, whatever that means. But you can't do therapy with a mouse during, the session.
As you get a smart mouse. Okay,
yeah,
thank
you.
you.
Or you speak a new language or something. So yeah.
I will, not, hopefully somewhat related. I'm going to try to throw this in the chat. It's actually a paper that came out of Yale, I guess last year, 2021 rather. So this was admittedly somewhat of a small sample size, but just looking at, ketamine alone versus ketamine plus cognitive behavioral therapy in people with treatment-resistant depression, and finding that the combination of, like, basically CBT prolonged the antidepressant effects of the ketamine treatment. So just to suggest that, again, admittedly, one study, relatively small sample size, just to say that, hey, this combination of ketamine plus, in this case, CBT, seemed to be helpful. So for whatever that's worth. Scott, you've got your hand raised, so feel free to unmute and ask your question.
I just wanted to make a couple of comments on what's been discussed so far. And so, S-ketamine not being helpful for suicidality, or that not being documented, might be more related to the frequency and the route of administration that it's administered. And I would say anecdotally, people with anxiety symptoms need to use the medicine once every 3 days. And the anxiolytic effect only lasts about 3 days. And so treating people with the medicine more frequently seems to generate more of a positive response. And then the treatment protocol that we use, we follow the research of Sanacora. And I was pretty certain that his research said that the treatment dose for depression is lower than the dissociative dose. And it's 0.5 milligrams per kilogram. So translating that to a sublingual dose, we treat patients with a dose of between 200 and 400 milligrams once every 3 days if they have significant anxiety symptoms, and once every 7 days if they only have depression symptoms. And our patients don't dissociate with that dose, and our patients respond. And so we see a positive response in about 50 to 60% of the population. And then treating those people that are positive responders on a regular basis seems to be very helpful for them. And so, in my opinion, the most important part of treating somebody with ketamine is determining whether they are a positive responder or not.
Yeah, interesting.
Scott, you administer up 200 to 400 milligrams, and the patients don't dissociate at that dose. That seems like actually a relatively moderate dose. Or certainly much higher. I mean, 0.5 mg per kg is...
We titrate to effect. And so we start everybody, we base their dose on about 1 milligram of ketamine sublingual per pound of weight. And so people are starting with a low dose that's around 150 milligrams or 200 milligrams, and we're increasing the dose to effect on a 30-day basis. And so people develop a little bit of tolerance to the psychomimetic side effects of the medicine over months. And so I would say, as a general rule for our patients, they do not require dissociation to have a positive response and improvement of symptoms of anxiety, depression, and suicidality.
Thanks.
And we've been treating some patients for 2 years now, and they stay on the same dose of ketamine. And over time, they don't have any psychomimetic side effects or any feelings anymore when they take the medicine. But anecdotally, the antidepressant effect and the anxiolytic effect persists.
I would concur with those
That's very interesting.
And I have no problem using ketamine long term. I obviously pay attention to people's bladders, but I don't have a lot of concern about using it long term. We'll see. I mean, it's new, and ketamine's an anesthetic. It's not been given long term since the 60s, but we'll see what it is. And also using pharmaceutical chemical ketamine rather than anything they might be using on the street, which is a whole different kettle of smelt.
Thanks for this discussion. Bridget, you've got your hand raised, so feel free to unmute.
Yeah, thank you. I'm excited to look more into the studies that you presented in the presentation and see more detail about what those include. I'm interested in, and you may have touched on this, but looking at the different receptors that ketamine is involved with and looking at the AMPA versus NMDA receptor effects on suicide in particular. And you know, I'm curious about the AMPA receptor pathway potentially being more involved in these short-term benefits and the anxiolytic benefits, and then the NMDA receptor influence on, you know, the more psychomimetic effects and like the longer term antidepressant effects that involve the actual psychedelic experience and perspective shift that then can affect ruminating thoughts and negative thought patterns. So I'm just wondering, when you showed the functional MRI information and different areas of the brain involved in suicidal ideation versus long-term depression effects, and if there's anything coming out as far as AMPA versus NMDA.
Yeah, that's a great question. And that's an active area of research. We have a study that specifically is looking at sort of AMPA throughput as the antidepressant effect. We give people perampanel, randomized to perampanel in the context of ketamine, which is supposed to block AMPA throughput. And so sort of there's that sort of more experimental design that we're looking into. But then, you know, there's sort of what you can deduce from sort of blood work and a couple of studies related to that. And then the imaging, the MEG work that I presented is particularly exciting. And I have to admit, I'm not the expert in that, but looking in that, and I'm happy to connect you with Jess Gilbert, who does do that work, because they are able to sort of create these virtual electrodes that appear to sort of capture on NMDA glutamatergic signaling as compared to AMPA. And sort of, we haven't been able to link one or the other yet, sort of AMPA versus NMDA to suicide in particular. She has been sort of looking at that as related to depression. But there's just with these new techniques, and especially these new computational models, I think there's a lot of really interesting insights that we could have, because it would be great to know, okay, is AMPA related to these depressive symptoms? And then is NMDA, like you say, is that sort of related to the dissociative effects, and sort of being able to differentiate that? I think that's a really exciting area. And I think we're going to have to do that experimentally, as I was sort of saying, like blocking AMPA and seeing what happens, but then also sort of looking at these biomarkers through sort of brain signals, or sort of looking at blood. And I guess CSF too.
Great, thanks.
All right, well, you know, if anybody does have any more questions, feel free to raise your hands and we can answer them, or, you know, you can ask them and somebody will try to answer them. It won't be me, probably. And I just, regardless, so I'm going to throw in the chat here just so people have it. That's the link to the Yale Psychedelic Science Group webpage. You might be on our mailing list, you might not be, but if you want to be put on the mailing list, you can go to that webpage and there'll be some instructions. And that way, you know, for any future events, if you want to be notified, we send out an email usually about a week or two in advance, and then another one, you know, the day of. So that's just a great way to stay up to date with what we're doing. You can also find, we have a YouTube page, our channel. So if you want to look at any prior meetings, recordings we've had, you can find a lot of them there. So I just want to share those resources with folks. Bridget, your hand is still raised. I'm guessing it, you know, it was more of just forgetting to take it down, but if you do have a question, by all means, go ahead and ask it. But otherwise, yeah, if nobody else has any other questions, I just want to say thank you again, Dr. Ballard, for taking the time to talk with us. Yeah, it's obviously an immensely important subject, and a profoundly challenging as well as exciting area or field of research. So I appreciate you for taking some time to share what's been going on in your work and in the field more broadly. So I guess I'll say too, if there's any last, before I close up here, if there's any last words or messages you want to share, by all means, I want to give you that opportunity and space.
No, I think this has been great. Thanks for your attention and for the interesting follow-up discussion. I really like going to different groups with different levels of expertise and familiarity. So that's always fun. So thank you very much.
You bet. And thank you all to the folks here who attended. Thanks for being a part of this experience, whether you were part of the Q&A or not. I hope you got a lot out of this, and I certainly did too. So yeah, I hope I can see or will see many of you at any future events. And yeah, I hope you all have a great rest of your day. So thank you.
Thanks.
All right. Bye, y'all.
Thank you.